last spring, in the midst of the beginning part of the pandemic, I did this series called Global Views of COVID-19, where we were looking at what was happening in the pandemic in different parts of the world with the idea that that would help inform our understanding of what was happening here. And one of the things I have been really interested in the last couple of months as I'm thinking about what's happening next is wondering, as I'm seeing other countries start to talk about it, what would happen when we got to the point where we had an appreciable portion of our adult population vaccinated, but the other portion not vaccinated and no kids vaccinated? Because to me, that seemed like something that would present potential ethical as well as just logistical problems. And here you guys are in California. It looks like schools are moving toward opening up. We're vaccinating people quickly, but still at this point, something like 6 or 7% of the population here is vaccinated. And so when Israel passed the 50% mark on adults vaccinated, I reached out to our guest today, Dr. Nadav Davidovitch. He is an epidemiologist and a public health physician. He's the director of the School of Public Health of Ben-Gurion University in the Negev in Israel, and teaches on health policy, public health, health promotion, the Israeli healthcare system, part of what got my attention, public health ethics and global health. And he is also presently a member of the Israeli National Committee on COVID-19. And so I thought this would be an ideal person to speak with us. I also included more of his bio in the description of the event. And I feel like it's fair to say that Dr. Davidovitch has been training for this year for a long time. So anyway, with that, I will have you share, and then we can open it to Q&A. And you all who are on the webinar, why don't you use, if you have a specific question you'd like me to direct at Dr. Davidovitch, why don't you use the Q&A button in the bottom and put the question in there rather than putting it in the chat. So if you want to comment and talk to each other, put it in the chat. But if you have a question for him, please put it in the Q&A. Okay. And I will leave it at that. I'm going to move to, yeah, I think that's good. Thank you. You're up.
Thanks a lot. Okay, so thanks a lot for inviting me. It's a great pleasure to be with you. Here is now evening, your morning, the miracle of Zoom and online. This is our world right now. What I'll do now, I'll share with you, first of all, the situation in Israel. And actually, we are in a very, very sensitive moment right now because we are in the third phase of our exit strategy from our third lockdown. And it means that from tomorrow, we're going to have also children 7th to 10th grade in places that are green, yellow, and mild orange. I will explain about it. And we'll also explain what we are doing in terms of a program called Protective Education or Education Shield. This is kind of a translation from Hebrew. Just about myself, as mentioned, I'm the director of the School of Public Health at Ben-Gurion University. I'm also on several advisory committees for the Israeli government and also on the European level. And before I start, I just want to say that I served in the military and was the head of epidemiology, and I'm dealing with pandemics, among other things, for the last 20 years. We did lots of drills and roundtables, including, by the way, with the Palestinian Authority in the past. Unfortunately, right now, it's a bit more difficult because of the political situation. But more broadly, I think that we need to remember that public health is not only COVID-19. Public health is about, promoting health in a broader sense. So it's about COVID and non-COVID health-related issue. It's not just about counting cases. It's also about mental health, about emotional and cognitive developments. And unfortunately, Israel was maybe one of the few countries that during this academic year was almost closed for education, and I think that this is a grave problem for the future. And now we are struggling to see how to open the system because, as mentioned, although we have a very successful vaccination campaign, there are no vaccines for children yet. There are vaccines from children for children that are 16 and above. We are all waiting to hear from Pfizer and other pharmaceutical companies about their clinical trials among children. We are vaccinating children age of 12 and above that are suffering from high-risk conditions such as diabetes and other different high-risk cases. Okay, so what I'll do now, I will share with you, just a second, I'll share with you my screen here. So this is the dashboard. It's in Hebrew, but I'll go with you and translate. It's quite easy. Now it looks very, very simple, but believe me, the beginning it was a mess, and it took quite some time to develop what should be the important indicators. So here you can see we have about almost 6,000 deaths since the beginning. This puts Israel somewhere in the middle. I think we are about 50-something country in terms of deaths. So we used to be, especially after the first wave, we were in an excellent condition. I will explain in a moment why things change. On the other hand, and I'll show in a moment, the vaccination rates, we have more than half of the population. Israel is 9.2 million people. So 4.9 million people already got the first vaccine, and 3.6 already got the second vaccine. I was vaccinated the second dose already more than a month ago. And now I'm allowed to have the green standard. We're not calling it a green passport, we're calling it a green standard. And as was briefly mentioned, it did raise lots of ethical issues that I will explain what is my opinion and what actually is happening now. We have now in Israel 690 severe cases. The standard was supposed to be 800, no more than that. Again, we are a relatively small country. It used to be 500, but more beds were added from the beginning, more ventilators, etc. We got up to 1,200, and this was mainly during January and beginning of February, and it was a really, really bad period, especially in hospitals. Although we need to remember that 99% of COVID-19 positive cases are treated in the community. So you have like, the different defenses. You have first of the public health services, then the community clinical care, and then the hospitals. I'm also sitting on a committee advising the government about developing the Israeli healthcare for 2048, its 100th anniversary. And we started to work just half a year before COVID, so we are now about a year and a half into it. And many, many things that we said already before were actually even more emphasized during COVID-19, like continuity of care, using telemedicine, the connection between the hospital and the community, many things that were actually strengthened if we want to think about the hospital of the future. You can see here, this is about vaccinations. You can see we started by early January. And here you can see what's going on in the last month. You see the first dose, we got up to 53% almost, and the second dose, almost 40% of the population. You can see here, and this is probably the most important one, you can see the vaccination rates according to age. So you can see those who are 90 or 80 or 70 years old are almost 96%, 95% first dose, and about 87% second dose. This is really amazing. What we want to do now, we vaccinating now those who are 16 and above. And of course, especially we are targeting those who are 50 and above and those who are suffering from chronic illnesses. Now, why we were so successful, I published several papers already on that. Shane, I can send you later, but very briefly, it's not just one factor, there are several factors. One, securing vaccines, of course. If you don't have the vaccine, you cannot vaccinate. And we see what's going on all around the world. Unfortunately, we have vaccine nationalism, so this is very problematic. We are pressing to have also the Palestinian people being vaccinated. We are not an island, and both for moral reasons and because of utilitarian reasons, it's very important for them to be vaccinated. We started to vaccinate now Palestinians working in Israel, but all the public health community is pressing to have all the Palestinians being vaccinated. It's very important for us, but you can imagine that this is also a political question, unfortunately. We have many Palestinians that are working with us. Some of them studied in Israeli universities. We used to have roundtables. There is a Middle East Consortium on Infectious Diseases that was very, very active. It's still active, but it's much harder since the second Intifada, and again, because of the political situation. Here you can see, this is really interesting, all different cities and settlements. And you can see, for every one of them, you can see how many are vaccinated first and second dose. What is the number of active cases? Active cases also for 10,000 people. And here you can see each city, each place is given like a grade. The lower is the better. And you can see that there are green places and yellow places. And you can see orange places. Okay. Now this is very important because we're trying. This is, for example, the red place. Just a second. See, 7.6. It's in the north. Now, unfortunately, there is a relationship between socioeconomic status and the vaccination rates and also active cases. And we have especially two communities, the Arab community and the ultra-Orthodox community. We're investing a lot of energies. So in terms of the success, we have, again, ensuring enough vaccines. And this is based on the idea that, Israel can serve as a model country. We are not guinea pigs. We are a model country because phase 3 is over. We're doing now post-marketing vaccinations, and we are doing surveillance, and we are obliged to give data for Pfizer, but also for the World Health Organization for all countries. And I'm very proud to say that one of the major articles about safety and efficacy was published using data from Clalit Health Services. It's the largest health fund, and 4 of the authors are also in my School of Public Health. So we're very proud. The article published in New England Journal of Medicine was written also together with Harvard School of Public Health and the University of Michigan School of Public Health. And it's now being followed all over. Also, the Ministry of Health is releasing data. In general terms, we can say that all the fake news, were refuted. The adverse events are quite minor, usually local, like redness or maybe fever that is over after 24 hours. Those cases are sometimes included also allergic reactions or some neurological effects are quite rare. We're talking about maybe some many hundreds, even few thousand, but up to from several millions of doses. So this is very reassuring. So we have Israel also with a national health insurance, public health care, available single-payer system. I really suggest that the US will adopt this one, but I know it's very political. Just for you to understand that in the 90s, when Hillary Clinton failed to move with, the health insurance law, so in Israel, both the Likud party and the Labour party, right and left, voted together to have a national health insurance system. So in Israel, it's not, health is not so, and the vaccines, it's not something so controversial like in the US, or not so political. Of course, everything is political, but it's different. So we have the health funds, we have electronic medical records that are enabling us to go all over the country. And I think that the third level is fighting fake news. This is something we invested lots of energy. And also I'm against compulsion, but we included several positive incentives. Municipalities became very involved. Some of them did some lotteries, or maybe offering, happening with food, giving pizza or falafel or different food according to the local community. Now, with the Arab community and the ultra-Orthodox community, there was a delay. One, because especially the Arab community are living more in the periphery, and it took some more time to open clinics, but the gap is being reduced gradually. And both in the ultra-Orthodox and the Arab community, there are lots of fake news and sometimes mistrust of the government, something that I know is also relevant for other countries. So there are fake news, that vaccines are actually causing infertility. That is very important for religious community. And we're fighting that because there is no basis and no any data actually supporting this. There are other crazy ideas, like vaccine including a chip that is introduced by Bill Gates. I don't know. On the other hand, you don't need to be just to dismiss. You need to be very open and, give empathy. And I think that many people are hesitant. And when you're talking to them, same level, and saying, I understand you think it may be a very novel technology. So actually it's not so novel because it's already, going on for 15 years. And all the stages, in the laboratory, animal studies, phase 1, 2, and 3, everything, there was no shortcut. Why so quickly? Because all the world is on it, because governments invested billions of dollars, and also the regulatory system was very, very keen to move forward. And I must tell you that the messenger RNA technology is very innovative, and it's going to revolutionize the medical system because it will work also against other viral diseases such as CMV, EBV, and also against cancer. And again, the data we have now already going on for several months on millions of people, nothing, surprising. No surprise. Here you can see the number of severe cases going down finally. And you see, I told you it was around 1,200. For the Israeli healthcare system, it was quite a lot. I won't go into the details of the numbers, but it's going down and down and down. The only explanation for that are the vaccines. And what we see now, that the age composition of those hospitalized is changing because those who are 60 and above are covered, and those who are 30 and 40, we see them more now in emergency rooms. This is very different than the first and second wave. We see more pregnant women entering the hospital. Now, part of the explanation is also the new variants that we have in Israel, like all around the world. Now, for every viral disease, there are mutations. When there is a mutation that is causing, a different protein, you call it a variant, and sometimes it can be a variant of concern. In our case, because it's influencing the spike protein. The spike protein is the one who is infecting the cells, and also the one that the antibodies are working to neutralize it. So when you have a series of mutation, it can create a variant, and it's a variant of concern if we're thinking maybe it's changing the spike protein. Now, I need to tell you that currently all the vaccines are working also against existing variants. There are some variants that maybe it's not 95% efficacy, maybe it's 85%, 80%. But this is, believe me, much higher than we thought. If last year you tell me that there'll be a vaccine with 95% efficacy, I'd say that you are so optimistic that you're probably, not exactly up to date. And these are really great news. So maybe there are some variants that the vaccine is working a bit less, but it's still working. And if we're going to have more and more people vaccinated, it's going to reduce the risk for more variants. Now, probably all the time there'll be more variants, and maybe sometime there'll be a new variant that will need to adapt the vaccine. Now, what is really great with messenger RNA vaccines, it's easier to change them and adapt them to the new variants, unlike other cases. So again, the reason we see this reduction is mainly because of the vaccines. And see what's happening here. This is the ratio of positive tests. This is very important because, sometimes you have, this is the number of the positive cases, and it can remain the same, but it also depends how many testing you're doing, right? So more important is to see the ratio, what is the percentage of positive tests, and this is going down. Now, I won't get too much into details because there are differences between different communities. In some part, the ultra-Orthodox community, they had R coefficient going up to 1.4. It was crazy. Now we're very happy that it's going down. And the Arab community is now suffering a bit more because also the UK variant that is now responsible for 90% of cases in Israel is infecting, faster, and it's now entering also the Arab community. Just to show you, this is the traffic light system, and you see the red, orange, yellow, and green. And again, in the last month, things are improving. And here you can see also the different, these are the cities that are still red. And there's a formula how you're calculating this. It's based on new number of cases per 10,000 people, the rate of positive tests, and also the percentage, the change in the percentage in the last week. Another factor that is influencing dramatically vaccination or influencing is how many healthcare workers are in isolation. And it used to be even 5,000. Now it's much less because many of them are vaccinated. This is the age composition of those who got sick, who are positive from the beginning. And see if I'm changing it to the number of deaths, you see that its age composition is changing. Those who are older, especially 70 and above, are much with risk dying. So in the coming minutes, Shane, I just want to say what is our policy right now. So as I told you, we are in our third phase of exit from the lockdown. I must tell you that for me, having a kind of total lockdown is always, in a way, a failure, because I think it's not proportionate. Sometimes you have no choice because we got into really very high numbers and you don't want the hospital to collapse, like it happened in Italy or New York or other places. I think that Israel could do much better with the education system. And I also want to say that from now onward, our strategy cannot rely just on vaccines. Vaccination campaign is very important, We still have about 250,000 people that are high risk and above 50 that we need to vaccinate, and we are doing it. And there's all logistics and all of that and incentives. But we need to continue with testing. We need to have rapid tests, especially in places like the education system. We are going to open from tomorrow also cultural events, sports, according to the green standard. So what is the green standard? The green standard, it means that if you had 2 vaccines and you're after 1 week, if you recovered and you have the certificate from your health fund, then you can enter according to certain standards, certain events. Now, because of the ethical issues, there are places that people can enter according to what we call purple standard, meaning that it's not based on vaccination, it's based on having enough space, all of that. And these are, for example, public transportation, because we think it's unethical not to give people that were not vaccinated, entering into groceries. But we do think that cultural events, going to a concert or going to a sports event, yes, people that are not vaccinated, it's a problem. If we want to give incentives for them to be vaccinated. And now the question, what about people who are not vaccinated? I personally thought that we need to give them the option to do rapid tests. It's already some kind of a stigma because we need to be on a separate line. And I think that most people that are hesitant, after maybe 1-2 times that doing the rapid test, this will, push them. It's like a nagging in behavioral economics, to do the right thing. In general, I think that I'm against compulsion, but I'm for having those incentives. And we need to remember that there's also the right not only of people not being vaccinated, but also what about the people who are vaccinated and are afraid to be infected by other people. We need also to remember that vaccines are 95%. Still, you have some chance to be infected. You can probably won't be developing a severe illness. And of course, the risk for death is extremely, extremely, extremely low, but you can maybe be infected and move it to your children or to other people. We know already that vaccines are reducing the risk for also infecting other people. It's not 100%, but it's also important. So from an ethical point of view, and Shane, I can send you a paper we published on this. First of all, remember that we want to get into herd immunity, and this cannot be done until the vaccine for children. But still, someone who's vaccinated is not just protecting himself or herself, also protecting other people. And in general, I think that being vaccinated is not just a personal decision, it's a decision that it's going to influence your community. So I prefer to see it as a way of solidarity. We are not afraid in Israel to use this word solidarity. I know that in the US, sometimes it reminds you like, I don't know, some communist slogan. So think about social justice. I remember that when I visited for the American Public Health Association meeting, it was in San Francisco, actually. I'm talking about 2001. So people were talking about solidarity. But this was related to a security event. I think that now we also need to return to this notion of community and solidarity. I think in the West Coast, maybe it's more.
We're a little more
prevalent.
We're more acceptable, yeah.
In California, it's more acceptable. Maybe then I don't know where. I won't give other places names. But I think it's not just the right of a person not being vaccinated is not just about individuals. It's also about the community. So it's more complicated. So again, I'm against compulsion, but I'm for positive incentives, even if sometimes it can create some stigma maybe. And this is maybe similar to smoking or other things that in public health that you want to use, but you want to be careful. So giving the people an option to do rapid tests, I think it's proportionate and makes sense. Of course, there are two professionals that maybe it's a bit different. One, healthcare workers, and second, teachers. That again, from different aspects, I think it's different than just a regular person. And I think these two professions, they have maybe higher responsibility to be vaccinated. So I'll be happy to answer questions.
That's a perfect time to switch to some questions here. So that's really helpful. And I especially think that what you were talking about with the green passport and like potentially making certain things available to people who've been vaccinated is interesting to think about. I have a few questions from the group, and hopefully these will also help get to the question of this new scenario in schools, right? Where teachers will probably be vaccinated, but their students will not be, and what that might mean about protocols in schools. So the first one here, which I think you can also see, Peter says, thinking about the success that Israel is experiencing, what do you see as a time frame for lightening social distancing or masking requirements? Or is this perhaps just the new normal?
I think we need to get to the new normal. I think that there can be certain events that are controlled, like a concert. So you can, for example, now in Israel, bring in 70% capacity, and right now, you can check, and now we have this green standard on our cell phone. But again, it's for me. I can show it. If I want to enter into, it's not that someone can stop on the street and ask me, but only if I want to get into,
showing that you've been vaccinated.
Yeah, or maybe if I recovered. Only a few days ago, for people that recovered, we're offering now one vaccine. It's a big discussion all over the world, but this is our policy. Now in Israel, it's also in some other countries like France and other countries. So people that were positive after 3 months, to give them another vaccine, it's like a booster. So we still required in Israel masks, especially because we have these variants that are much more infective.
And is that true in school too? If we can think about this inside of school buildings. So I think the teacher was asking about distancing and mask requirements in school, in the classroom.
Right. So we have in Israel a program called Education Shield, and it includes pooling. So it's a way of taking a PCR test from children, pooling, and then if the pooling is positive, you're taking from each child two tests. What we suggest in Israel, one is ventilating classes. Second, if you can teach some parts outside, it's also best. And having what we call it capsules that are of
we call them cohorts, groups of kids that stay together.
Yeah. So again, it depends. There is no right number. It can be 10 students. Can be
Are you
16.
Are you anticipating that situation continuing until children are largely vaccinated?
Yes.
Okay.
Or when we get more data that can say otherwise. But we have in Israel, since we got the UK variant, children are much more infected than used to be in the first and second wave. There are now 4 or 5 times more children infected. And we see now a big difference than used to be. Still, most children, the clinical, severity is much lower, but infectivity is going up because of the variant. So This is why we still required masks and all things that were there before. And we demand also that teachers will be vaccinated. Here it's a bit tricky. And there are differences in different cities, different regions in Israel. And I would say that teachers that are not vaccinated, maybe it's still under discussion, but I think it will be decided this week. So if they are not vaccinated, they will teach online only.
Mm-hmm. Yeah, I think that's interesting, and that gets at, I think, some of
It's
the
still under
issues here.
discussion, and even a Supreme Court petition on that from parents that want it to be required by teachers. Until now, it was not. I mean, they were asking them to be vaccinated, but I think, again, it depends on different regions, but I think on average, about 60 to 70% of them were vaccinated, but we want to get to 95%.
Thank you. Scott put a question in the chat, which I'm going to pull out here. He said he heard a discussion yesterday that suggested the benchmark for opening public spaces should be the equivalent of annual flu deaths, which is 30 to 60,000 a year in the US. What are your thoughts about that?
Wow, I'm not sure that we need to make this equivalent to influenza. In general, again, I think that in public health, you need to do risk management and remembering also that schools that are closed for so long, this has consequences also for the mental health and cognitive developments. It has also an effect on the economy. So within the experts committee, I was, and some of my colleagues, but some felt maybe a different way. They were maybe emphasizing more the risk. We thought that it's not a question, should we open, but how we should open. So we should open and use lots of creative ways, hybrid teaching. Now we have the vaccines, ventilating classrooms, teaching outside, all of that together, and opening all ages, and of course, including also what we call the education shield with tests. So this can be rapid tests, or this can be the pooling I suggested. So it's a multi-layer protection that we need to adopt. Just from historical point of view, in the early 20th century, before there was antibiotic and TB vaccines, BCG, all of that, we have lots of testimonies and pictures, children learning outside, even in Europe. By the way, California at the turn of the 20th century was perceived as a healthy place to send people with TB to, especially to LA. Now maybe it sounds strange, but I'm talking about because of air pollution. Because of air pollution.
No, I understand. It's fire season.
LA was perceived as a place to send TB patients.
Yeah. So I have two more questions here for you. I'm sure we'll have others. And I think you sort of answered this, but I just want to get, so teacher Judy says she's wondering about testing protocols. And I heard you talking about pooling. So that's where you take samples from, say, all 18 kids who are together in a cohort and gets tested as a single batch. And if anything comes back positive, you treat it as a positive. So for those of you who hadn't heard or didn't understand what he meant by that, it's a way of doing a PCR test more cheaply and more frequently. So Judy says she's wondering about testing protocols. While we roll out vaccinations, our school district will be testing staff and students every other week based on cases per 100,000 in our county. Do you think this is valid? Do you think this is meaningful to prevent spread through schools reopening?
Yes, definitely. This is what we're doing in Israel, and it's very successful. So exactly this policy, exactly.
And as a follow-up to that, are rapid tests available over the counter or more easily in Israel than they are here, perhaps?
Wow, this is a very, um, I won't go into all the frustrations, but only last week Israel approved 4 companies. So all the rapid testing in Israel is very, from different reasons, developed very, very slowly. Not we had all of that, but it was, I think, some conservative way of the Ministry of Health, and it's part of older discussion about it's a complicated issue related to false positive, false negative, positive predictive value, negative predictive value. I won't go into it, but now there's lots of pressure, especially because of the ethical question. So even though it's not perfect, I see that now after the Minister of Health last week approved the 4 different rapid tests, antigen tests, they will be used in different contexts. One of them is our schools, but of course it can be also for cultural events. And I think it's especially important from the ethical point of view when you want to bring in to different activities those who cannot vaccinate or who refuse to be vaccinated.
Yeah, a way of making that accessible. Carol asks, is there any information regarding the duration of immunity from vaccine versus natural infection? Does it look like it's the same or different? We're vaccinating people who have previously been infected. That would indicate the thought is that the immunity from vaccine lasts longer.
Wow, this is an ongoing question, and no, if someone tells you that they know for sure, don't believe him or her. We still continue to do follow-up. In Israel right now, the vaccines are, giving you the green standard for 6 months. But I quite positive that we have already data showing that it's at least 8 months, but probably even more. But again, it depends not just about, in epidemiology, we have the triangle, of the pathogen, the host, and the environment. So the pathogen is also changing. It's not just about the host immunity. So we know now that there are people that were infected with the original strain and now with the New York strain, South African, Brazilian, all of them, they maybe get a second infection. So it's not clear yet. In Israel, officially, again, because we need to make some regulation, so it's 6 months for vaccine and 9 months for natural. But it's clear also that different natural infection can give you different, because it depends on the viral load and the specific strain. It's not clear yet. Again, there is an option that maybe we're going to have a seasonal vaccination, like with the influenza, although it's a different vaccine, but it's not clear yet.
Okay, thank you. Mila, I hope that sort of answered your question too about the antibodies from having COVID protecting people, that it depends upon a number of different possible changes. I want to frame for you a tough ethical question that a teacher asked me yesterday. So he is not in California, but this is something that certainly could happen in California. His school is reopening full time. He has a classroom with windows that open and a door that opens, but not a tremendous amount of ventilation. And beginning in a couple of weeks, he will have all of his classes back full time. And he's been told by his district, space them out as much as you're able to in each section, which means that some classes he has 34 students and he knows he won't be able to keep them more than 2.5 feet apart. And then in his advanced classes, his AP class, he has 15 students. And in this country, AP classes, especially in certain districts, are very closely correlated with other types of economic privilege. Like the kids who end up in those classes tend to be often, not always, better off. So the question he's faced with is, he has 5 classes during the day and he has the capacity to keep his more privileged students farther apart from one another than his poorer students. What should he do?
Wow, I think that the most important thing is to take all the stakeholders, including the parents and teachers, and think about innovative solutions. Again, I mentioned some of them, maybe doing some hybrid teaching, teaching outside. And I don't think any of those it's a perfect answer, but it's probably a combination. Um, I truly believe, and that's what also I'm suggesting in Israel, that we cannot have a copy-paste solutions. We need to discuss things, including risk management with all the stakeholders and see together what can be done. And I think that the question of inequalities is a major factor here, and what can be done. And again, you can have like 5, 6 different things, like again the ventilations, hybrid, teaching outside. Uh, Maybe also having class. There are places where you put like I don't know how to say it in English.
The
Like
divider.
yeah, yeah, yeah.
Yeah,
So
unfortunately, the situation I just posed to you is what happened. That's what the union was able to win. Like all of what you've talked about has already happened there. This is,
okay,
and part of the reason I'm framing it this way is because I'm sorry, I'm not trying to put you on the spot. You don't have to solve it, but I think that this is like the reality for teachers at this point here, where they're being sent back and told like, this is what we came up with. Now you do the best you can. And so his scenario is he knows what his furniture is, he knows what his windows are, he doesn't have dividers, he knows the students will be wearing masks, and he has no choice about having this number of kids in his room at each time of
yeah,
day.
I think that
And
having
so,
a sincere discussion with the community and all the stakeholders is the most important factor, and try to find not to put all the pressure upon himself or herself, and working together and understanding what are the options. I'm sorry that I cannot,
you
but
can't solve our conundrum. Yeah.
yeah, no, I think that having some roundtables, but with all the stakeholders, sometimes you can get a better solution. And finally, it's you cannot have a risk-free kind of teaching.
Mhm.
But I don't think this should um, interfere in returning to some new normal, as we call it.
Yeah, I think it's a difficult scenario for everyone involved in trying to make those choices. I'm glad I'm not in his position, is all I have to say about that. Do you all have one more question? We have 2 minutes left, and I also have a poll that I want to give you at the end. It's very fast. I'll give you a moment to think and type anything in if you want to.
I see here a question. Can you speak of situation where you did reopen schools previously and there were
Oh, and
infections?
I'm sorry, I missed that. I didn't see that. My
Yeah.
apologies.
No, it's just appeared. Yes, of course, we saw such cases. This is why it's also important to have the testing system and to try and get these kind of infections as quickly as possible, and do the contact tracing and the epidemiological investigation. So this is why the tests are very important. Either rapid tests or the pooling that I mentioned. So if you got this kind of event very early, so I don't think it's too much of a damage, and you stop the transmission as fast as you can.
I think that's a helpful answer. Mila asks a follow-up. In those cases, were kids more frequently infected than adults?
So again,
oh, in those cases were, I think that says were.
So in the first and second wave, no. Currently, children are with the UK variant, and again, it's now responsible for 90%. Children are much more quickly infected. So it's a it's kind of a change all of our models in this third wave.
Yeah, and we'll see what happens here because we're looking at that becoming the primary variant, I guess, in California in the next month, I guess, I think is where we're
Yeah,
at.
yeah,
Yeah.
yeah.
Okay, we started a little bit late. Do you want to stay another 5 minutes and take any additional questions if people have them?
Yeah, maybe one or two more questions.
Okay. Does anyone else have another question they'd like to ask? It's so strange to do this and not be able to see anyone's face or handwriting.
So where are you physically now, Shane? I'm in Tel Aviv.
I'm in Berkeley in my office, in my house, and there are people on here from many are from California, but I know there's one from Arizona and a couple of other places.
Interesting.
And Peter says he put a question in here. He says, I really appreciate what you're saying about stakeholder engagement, but at least here there seems to be a huge fracture between parents and teachers / school districts. Is that the case in your experience? And has there been any success in rebuilding those relationships in Israel?
It really depends where, and I think, COVID actually, it's like facing a mirror in front of us and exposing all the tensions and things that were before. So I would take it as a chance of building trust. I'm not saying it's simple, but it's an opportunity because of the emergency situation. And sometimes you need maybe a facilitator or someone, a mediator. But I won't escape this kind of hard discussions because I think that it can serve as building something different. My wife is a law professor and she was the director of a conflict resolution program. And so I learned from her quite a lot. And also in healthcare, we have lots of conflicts and conflicts also bring ethical dilemma. Usually ethical dilemma is when you have conflicts. So mediation and it's
Yeah.
I think we should take it as an opportunity. I'm not saying it's simple, but I think it's an option.
Well, that's a somewhat positive note to end on. I'm gonna post the poll for you guys if you could take a moment before you go. That would be very helpful. It's very short. And I want to thank you again, Nadav, for taking the time to do this. I sent you a cold email and I really appreciate you being willing to hop on and just talk to a group of teachers around the world.